supracochlear, then this nerve, okay, and the main nerve. They are easily visible because these nerves are superficial branches, so they can be seen easily. But other branches, like the mandibular, like the maxillary, they are a little bit difficult to locate with the help of the ultrasound because they are quite deep. Number one, the nerves as such cannot be seen clearly. That is our main point. So what we have to see? We have to see closed vessels like internal maxillary artery. But remember, it is quite inside. Even with the view that we see in the cranium, is my picture clear? I am a little bit doubtful because in my computer I am not seeing it very good. Is this okay? This picture?
Picture is okay, but yes,
It should be more clear because to see
yeah,
the
it is not that clear.
now, is this better?
Yes, yes, yes,
I think
better.
this is better now. Okay, though some grains are there. I wish there is no grains, but unfortunately some grains are there. Let's see with the quality. We are taking it an HD quality. Now I think it will be comparatively better. Yes, now it is better. So, because why I am asking again and again this picture, because there are a lot of understandings that we need to understand with this color only. Because unless and until the concept of these areas are very much clear, you will be having trouble in doing the procedures. So let's start with the trigeminal nerve. So the gastrian ganglion, we know one of the largest ganglion for the trigeminal nerve that resides into the Meckel's cave inside the cranium. It is usually in the middle cranial fossa. Now the question comes, after so many years, how to remember which one is the anterior cranial, which one is the posterior cranial, and which one is the middle cranial fossa, and what are the bones forming these fossas, and what are the structures, what are the foramens. This is usually a difficult job when it is asked in the first year in MBBS examination because they usually put a probe and ask what are the structures going through this. So that was the common question here in Kolkata. At your place might be the same. So let's see. These are the three cranial fossa. So first this one, you can say this is the one step. You can say this is the most superior step, that is anterior cranial fossa. This area is the middle cranial fossa because this is comparatively in a deeper area. Or down. So it is the second step. And this is the third step, or this is the inferior cranial, sorry, posterior cranial fossa. So this is the last step. The brain is situated in stepwise pattern within this cranium. Now the bones forming this cranial bone or cranial part, important part is anteriorly. Here we are having the ethmoid. Okay. So here what bone I am touching is the ethmoid. It is very difficult to seeing the picture and putting the probe here. Here you can see the needle, I am on the ethmoid. And the projection you see just in front of my needle, it is known as the cristalli. Okay. And just by the side of these projections, there are small plates with multiple small foramens. Okay. These plates are known as the crepiform plates. Can anyone tell which nerve goes through it? Which cranial nerve goes to the crepiform plate?
Olfactory nerve.
Olfactory nerve.
Perfect. This is the first cranial nerve or the olfactory nerve. They come to the crepiform plate. So crepiform plate is a part of the ethmoid bone. Anteriorly, this bone is connected with the frontal bone, and there is a small bone here, which is just by the side of the nose. That is the nasal bone. They are closely related with the ethmoid bone. With the ethmoid bone. Now, by the side of the ethmoid, we have this margins. You can see this is a margin, and there is another margin on the opposite side. Okay, so this is also a margin. So, which bone is forming these margins? Can anyone remember? The posterior margin of the anterior
Express part
cranial
of
fossa.
temporal.
This is the ethmoid.
Express part of the temporal bone.
Excuse me, voice is not clear. This is the lesser wing of the sphenoid.
Ex-
So sphenoid is having two wings. One is the greater wing and another one is the lesser. So this anterior portion is formed by lesser wing of the sphenoid. And these processes, anteriorly we have the anterior clinoid, then we have the middle clinoid, and posteriorly we have this is posterior clinoid process. So we have three bony projections here at this point. But this was just an introduction. Our main component lies here at the middle cranial fossa. So just look it carefully. I am taking it much closer to the camera. So here, if we see there are multiple foramens, among which few foramens are very important for us. I am rotating it slightly. First, I am rotating it slightly towards the anterior side, then I am rotating it towards one side. So we can see there are three foramens. Okay, the first foramen is this one. Okay, so I am putting the probe. Let us in normal size you can see. So you can see this foramen. Clear? My needle is going through it. Can you see this?
Yes.
This foramen. It is the superior orbital fissure, not optic, because optic nerve goes to the optic canal. Through the superficial orbital fissure, the nerve goes is the first division of the trigeminal nerve. That's why I am showing it. Okay. So this is the superior orbital fissure. I am again showing it. So you can see here the needle is going to the superior orbital fissure. Okay. This is the first branch of the trigeminal is going through it. Then from which area the optic is going? Optic is going through this foramen. You see this foramen. Okay. These foramens are different. This is the optic canal through which the optic nerve goes. So I think you can see it clearly. No? This is the optic foramen. Let me try to focus. This is the optic foramen. You can see this is the optic canal. And just by the side, we have the superior orbital fissure. This is the superior orbital fissure through which the ophthalmic division of the trigeminal nerve goes. Clear? So this is the fifth cranial nerve, anterior division. Okay, so this is the very important foramen because the branches what is coming here at the supraorbital and the supratrochlear area, they are all branches of the ophthalmic division of the trigeminal nerve. Okay, now let us go to the other foramens. Now the second foramen which can be very easily targeted, and you can see this foramen, it is very clear. Easily you can see this foramen. So I think everyone can say which is this foramen. It is very simple.
Foramen ovale.
Yes, this is the foramen ovale. So it goes below in the infratemporal area. So it is going at the infratemporal area. Very clear. So, but after coming at the infratemporal area, where it is remaining? It is remaining posterior to this plate. Here, can you see this plate on which I am putting my index finger? This plate, this is the lateral pterygoid plate. This is having immense importance in our procedure. Okay, because just posterior to this plate, we are having the mandibular division of the trigeminal nerve, which is coming out from above. Now, we have a third foramen, but we cannot put a needle from the opposite side of that foramen because it doesn't communicate with the exterior directly. I'm trying to put the needle from inside and I am showing. Okay. So can you see another foramen here? So we just anterior to this foramen, we are here in the picture slightly above. We are having the superior orbital fissure. Just anterior and medial, we are having the optic canal. And just posterior, we are having the foramen ovale. So which one foramen is this? This foramen?
Rotundum.
Foramen rotundum.
This is the foramen rotundum. So through which second division or maxillary nerve of the branch of the trigeminal nerve that goes. But remember, where it goes, it doesn't come outside because from outside I have told you I cannot put the needle from the opposite side because it is not a straight line. So where it goes, let's try to see where this needle is going. First one. So I'm again putting it and I'm trying to see the same needle from the lateral side. See, from the lateral side is difficult, but still try to focus. See, can you see the probe now? Here it is. Can you see my cursor and the needle coming? See, can you see? That is the first important thing. And put
Yes, sir.
Yes, sir.
Anterior part of the pterygoid plate.
yes, it is not the anterior part of the pterygoid plate, rather it is in front of the middle pterygoid plate because
Acha.
this is what you can see from the lateral side is the lateral pterygoid.
Yeah.
On the inner
I can't
side, we
see.
have the middle
Where
pterygoid.
is it? Where is it? Doctor, it's not clear for me. Where is it?
Okay, just one second. Just focus at this point. Okay, my cursor you can see. Can you see my cursor or not?
Sir,
I think
can
you
I
cannot.
tell you a suggestion, sir?
Yes.
When
No,
you
your cursor is not seen.
Oh, that is the problem. Okay. So what is the suggestion? How can I show this?
sir, when you show the skull, if you don't show your face, it will focusing well because I think the camera is trying to focus your face. That's why the picture is not clear.
I am removing my face just behind the camera, okay, behind the skull. So now is it clear? See, just you try to focus on the zygomatic process, zygomatic bone. Just below the zygomatic bone, anterior to the lateral pterygoid plate and posterior to the posterior wall of the maxilla. Can you see a gate? Another bone or any structure. Can you see this opening, this gate? See, I'm removing it. Just try to focus this gate. Can you see now? So there is no response. It is very difficult for me.
Can see the tip.
Yes, can you see the tip of the needle? There,
Yes, sir,
going
can
on.
see the tip.
Yes, sir, I can see.
Okay, fine. So this is the area where the mandibular division is coming. So this area is known as the pterygopalatine fossa. Okay. So what are the boundaries of the pterygopalatine fossa? Posteriorly, we can easily say it is bounded by the medial pterygoid plate. Anteriorly, okay, just to do a spotlight. Let's see. Let's do the spotlight for everyone. Okay, continue. Okay. So let us what we are discussing. So try to imagine the boundaries of this area, the pterygopalatine fossa. Okay. Anteriorly, it is the posterior part of the wall of the maxilla, especially the maxillary antrum. Maxillary antrum is here. Okay, here is the maxillary antrum. Okay, and this is the maxillary antrum. So the posterior part of the wall of the maxilla is which is forming the anterior border. The lateral pterygoid plate ends here, and from there the medial pterygoid plate starts inside. So medial pterygoid plate forms the posterior boundary. Medial boundary is formed by the portion of the lateral nasal wall. Okay. So what are the components of the lateral nasal wall? If you can remember the components of the lateral nasal wall from superior, it is the superior nasal concha, which is the part of the ethmoid bone. Then we have the middle nasal concha, which is also a part of the ethmoid bone. Then below the middle nasal concha, we have the inferior nasal concha, which is also a independent bone. It is not a part of the ethmoid bone. And it connects with the perpendicular plate of the palatine. So these are forming the lateral nasal wall one by one. So first part is the ethmoid. There are two concas with that. That is the usual. Sometimes there might be three concha as well. That is known as the supreme nasal concha. But first superior nasal concha, middle nasal concha, then independent bone, inferior nasal concha, then it is the perpendicular plate of palatine. Okay. So they are actually forming the medial nasal wall. So they are the medial relation of this area. Why this is important? Why I am talking too much about the pterygopalatine fossa? Because pterygopalatine fossa is our area for the blockage of the maxillary division of the trigeminal nerve and its branches. So there also we can block the sphenopalatine block ganglia. There also we can block the palatine nerves. So all three nerves can be blocked on the same area just by from the lateral side, just by going through this gate. Okay, so this is our gateway for that. So this concept should be clear, but this is a little bit incomplete because here there is another structure, that is the mandible. So let us show you how it looks with mandible. Okay, so where we can go actually to this area. So let's take a scan, share. So in any step, if you are not able to understand any portion of the anatomy, please let me know, because with fluoroscopy it is difficult when you are seeing the bones clearly. With ultrasound, it becomes more difficult because you are not seeing the bones clearly. So it is very difficult unless and until you understand the bone anatomy clearly. So here we can see this is the zygomatic bone. Okay, it is not selecting separately. So this is the zygomatic bone. Just below the zygomatic, we have the condylar process and we have the coronoid process. These are the part of the mandible. So if you look in between, so in ultrasound, one thing you make sure that you will be posteriorly seeing this structure, then we will be seeing this structure, then we will be getting the gap, then we will be seeing the coronoid process. So one by one, and your focus will be within this gap, within this coronoid notch. Now let us hide the mandible. Then it will be easier for you to understand. So hiding the mandible. Now at this point, see if we look slightly from below, we have the lateral pterygoid plate here. Okay, this portion is the, I have to draw because otherwise it is, this portion is the lateral pterygoid plate. Okay, then just posterior to the lateral pterygoid plate, here I am drawing in the red, it is the foramen oval. So the mandibular nerve will be coming like this. So we can block first by seeing the artery accompanied with it. So remember, here also, even with the ultrasound, clearly finding the nerve becomes difficult because its depth is almost at the level of the 6 to 7 centimeter. Because lateral pterygoid plate, the usual depth is around 5 centimeter. So it is further more deep. In that area, finding the nerve is difficult. So we have to look at the mandibular artery. Okay, let's undo this drawing. So clearing the drawing. But there is another structure. If we go slightly anteriorly, okay, then we are getting this area. Okay, so what is this area? This is our gate. That gate I was showing now of the pterygopalatine fossa. This is our gate. So posteriorly it is bounded by the lateral pterygoid plate and anteriorly it is bounded by the posterior wall of the maxilla. So we have to pass the needle through this gate. So let me draw. This is our gateway to the pterygopalatine fossa. Remember, it's a very small area. Though some researcher has said that they have seen internal maxillary artery with the help of the ultrasound. Remember, number of studies are really few, 5-6 studies are only there. So even though seeing an artery here is difficult because they are not always in a straight line, first of all. Then there are multiple branches of the external carotid here. So finding out which one is the exact internal mandatory, it's difficult. But what is easy? Easy is putting the needle through this gate. Remember, even with the fluoroscopy, what we are doing for years, okay, we are doing the mandibular division block, we are doing the sphenopalatine ganglion block, we are just following this gate only. After this gate, we are just seeing whether it is going and touching to the lateral nasal wall or not. Here also we have to touch the lateral nasal wall. So by just feeling that we are putting it there, and then the stimulation is our only way to find out whether we are close to the maxillary, whether we are close to the sphenopalatine, whether we are close to the palatine. So in that video, specifically Okay, Dr. Manjari, actually there is a way that I got it. Can you please enlarge your video picture? Okay, if you want to enlarge
I
my
got it.
picture,
I got it. I got it. I got it. Thank you.
you have to
Thank you.
pin it actually.
Yeah,
Pin
yeah.
the picture.
Yeah, I got it.
Okay.
Thank you.
So the thing is, what here ultimately our target is to going to that area and touching perfectly with the perfect nerve. Ultimately, for that we have to depend on the stimulation parameters. So now, how is the gland situated? The ganglion situated. So the ganglion is situated at this point here. I shall be showing the picture. But three divisions are going anterior, mandibular, and foraminal in between this. So it is was very easy when we put needle for the trigeminal ganglion block going through this area. Okay, but remember this much interior we cannot see with the help of the ultrasound. So if you say, is it possible to find two-way Gaussian ganglion block through the ultrasound? It is not possible because there are multiple foramens and we cannot go there. And there is another foramen very close. I have not discussed. Just behind there is another foramen. Okay, you find it. I am putting the probe here. There is another foramen. This foramen is the foramen spinosum, and foramen spinosum actually gives or passes the first recurrent meningeal branch from mandibular division. That is the first branch of the mandibular division of the nerve. Then comes back and it's a recurrent meningeal branch that goes through this foramen. Remember, maxillary also gives one recurrent meningeal branch, but it is at the level of the cranium. So before coming to the rotundum. So let's start the presentation. So anatomy portion is clear because otherwise everything will be difficult. So if everyone is clear with the anatomy, I will go with the next portion. Okay. So let's go with the presentation. Okay. So nerves of the face and the interventions with the help of the ultrasound. So if you see the areas, definitely we can divide which area is supplied by which nerve. So ophthalmic nerve supplies this much of area. The mandibular area is this area. So in the patient complaining of the pain in these areas, we can differentiate that which area is supplied by which nerve. Probably that branch is affected. So the patient is having a shooting pain here at this point. Definitely it coming from the maxillary division. If it is going at the ophthalmic area, sometimes can happen with the zoster also. At the zoster, this is carried by the ophthalmic branch. And here lower portion is the carried by the mandibular branch, and the posterior portion is supplied by the cervical nerves, mainly R3, greater and third occipital. The lesser occipital is actually not a branch from the posterior division, rather it's a branch from the superficial cervical plexus. So superficial cervical plexus gives branches and they are covering this area. So greater occipital, great auricular and the lesser occipital. So they are supplying this area. We have the supraclavicular nerves. So this area are all supplied by the branches of the superficial cervical plexus. So here our concern is mostly to the anterior area. Now you can see the picture and one by one how the nerves are coming. So here we can see this is the Cassidian ganglion. V1 division is coming through the superior orbital fissure, though the accompanied artery is not passes through the superficial orbital fissure. Rather, it passes with the optic nerve. And then it goes into branches, among which there is the ciliary branch, there is the nasal branch, and the lacrimal branch. Okay. So these branches are supplying mostly the orbit and the surrounding area. Similarly, the maxillary division, they first passes through the cranium, gives the first branch here, and that comes back to the meningeal branch. Then it goes and comes into the bone, that is the maxilla. But here at this point, it is in between the maxilla and the sphenoid. And this is the area which is known as the pterygopalatine fossa. So in this fossa, it gives certain branches, among which most important is the branches to the pterygopalatine nerves. They are the branches to the sphenopalatine ganglia. So they are giving branches to the sphenopalatine ganglia. That is one branch. Then sphenopalatine ganglia receives another very important nerve here. That is the median nerve, which is actually formed by the joining of two nerves. One is the greater petrosal nerve, one is the deep petrosal nerve. Remember, deep petrosal nerve carries the sympathetic sensation, which is mainly from the T1 and T2 division of the lateral horn, and the greater petrosal nerve mainly carries the parasympathetic sensation, which is mainly carried by the facial nerve nucleus. Okay. From there, they are combining, joining together, and they are coming at the pterygopalatine fossa. So at the pterygopalatine fossa, they are forming and they are joining and we are forming with this ganglion. Then from the phenopalatine ganglion, the nerves go down, they are the palatine nerves, and this supplies the palate area. Branches grow to the lacrimal area as well. So that is the maxillary division. Then there is the mandibular division that straight away comes down and supplies the mandibular area. Remember, there are branches from the trunk. The first branch I have already told you, it is the recurrent meningeal branch. It goes back to the foramen spinosum with the middle meningeal artery, and the rest of the branches they mainly divides into two divisions, anterior and posterior. But before that, from the main trunk, it also gives some important branches. So I'll come one by one. So first, start with the how they are starting from the cranium, dividing some branch going to the first branch going to the superior orbital fissure, then the second branch going to the foramen rotundum, third branch going to the foramen oval. Now, as this is a comparatively advanced course, I will not be repeating this very basic things like trigeminal neuralgia. Hopefully, you already know the basics of the trigeminal neuralgia. Okay, so in short, it's a pain which is agonizing, paroxysmal, shooting in one side of the face, and limited to one or more divisions of the trigeminal nerve, which is triggered by chewing, speaking, touching the face, etc. Neurological examination in idiopathic trigeminal neuralgia where no cause is found or an apparent vessel compressing the trigeminal root entry zone. So in all those cases, no neurological abnormality will be there. Sometimes it could be secondary, and secondary trigeminal neuralgia is mostly due to a sometimes CP angle tumor, sometimes multiple sclerosis. So they can cause the secondary trigeminal neuralgia. Now, if you compare with the divisional distribution, the most common is the V2 plus V3, that is the maxillary plus mandibular, followed by the V2 alone and all divisions, and rest follows thereafter. V3 alone, then V1 plus V2, then V1 alone, like that. And it is more female preponderance, and the peak incidence 50 to 70 years, and sometimes patient is having the family history. So to diagnose, these are the following questions commonly asked. That is whether the pain comes in attacks or not, whether the attacks are small duration or not, whether the attacks are unilateral or not, does the attacks occur in the region of the trigeminal nerve or not, whether there are any unilateral autonomic symptoms or not. Definitely, for trigeminal neuralgia, first four questions will be yes, and the last question is usually no, because unilateral autonomic features are the feature of the group of the disorder which are termed together as the trigeminal autonomic cephalalgias, which is actually part of the headache. And there we could see the unilateral autonomic feature, and these are not present in the trigeminal neuralgia. Among the unilateral autonomic features includes there could be lacrimation, there could be puffiness, there could be congestion of the eyes. So these are the features of this unilateral autonomic features which are not present in the trigeminal neuralgia. Now, one thing is very important. We have to do a thorough neurological examination, and ultimately we have to rule out with the help of the MRI if there is any secondary cause is present or not. Okay. Now we have to do the differential diagnosis check for it, especially the possible differential diagnosis that could match with the trigeminal neuralgia features are the idiopathic facial pain, and this is known as the non-specific facial pain. That's an entity which causes a vague pain in the face, and treatment is usually the gabapentin. This is a very rare and chronic condition that could be a differential diagnosis, but here the shooting character is not there. It's a dilating pain, and the dermatomal distribution, I mean not dermatomal, but here the distribution is like the divisional distribution is usually absent. TMJ arthrosis principally causes obstructive pain. On chronicity, it could possible that it can cause neuropathic pain. And if there is TMJ arthrosis, you have to rule out this condition. And usually, TMJ arthrosis can be simply ruled out by putting local anesthetic in the TMJ. And sometimes, this is one of few of my experiences actually. In one patient, initially I diagnosed trigeminal neuralgia. I did the gastronomic ganglion radiofrequency, and after that I found that the neuropathic component of the pain is gone, but still the patient is having the ankylosis and not able to open the mouth because of the TMJ arthrosis. Then we have to go for the TMJ injections twice. Finally, the patient become pain-free. Last 1 year, she is very good. Next comes the dental disorders, but remember, usually things becomes opposite. We do not have to differentiate the dental disorder. In most of the cases, we get the trigeminal neuralgia patient referral from the dentist only. So usually they have treated and they have examined the dental part, and then they usually send us. But for you as well, if you are suspecting there could be possible dental disorder like a caries or other thing in the teeth, you should send the patient for a dental examination as well. Then migraine would be another possible differential diagnosis. But one thing is very important. All patients should undergo an MRI scan. Before that, you should not the procedure. Then comes the drugs. Before drugs, one thing is important, the drug treatment of choice. In young patient, it is definitely the microvascular decompression because as per studies, they can give more long-term result. But if the patient is elderly, the treatment choice is usually radiofrequency. If it goes and involving the first division of the trigeminal principally, the could be possible better treatment option could be a balloon compression. Now, regarding drugs, these are the drugs and dosage commonly given for the trigeminal neuralgia, but there are some pros and cons, side effects, everything is there. And today, during the procedure, we should not go detail into these drugs, but these are the basic drugs we usually start, and we go for the intervention only when it is not responding. Among the treatment options, we are having the surgical microvascular decompression, we are having the stereotactic radiation therapy, percutaneous balloon microcompression, percutaneous visceral rhizolysis, percutaneous RF, and gastric ganglion stimulation, which is not in clinical use till date. But so, what are the most common procedures what we do? First of all, it is definitely the radiofrequency. Then those who are not having the radiofrequency, they can go for the neurolytic injection in the trigeminal ganglion, or balloon compression could be another alternative. And in some patients, very aged, and there are other contraindications, you feel the procedure may not be safe, you can send the patient for the SRSS, that is the stereotactic radiation therapy. But ultimately, though till few years back, it was thought the effect is much less, but there are few studies that came up with that from the radiotherapists that they are also giving almost equivalent result with the standard technique like radiofrequency ablation. Now coming to the blocks, what is possible for us with the ultrasound? So first of all, these three blocks can be blocked very easily. So what are these blocks? First of all, it is the close to the supraorbital foramen. It is going the supraorbital and the supratrochlear branch. So we can block at that area. So if the pain is around that area, it could be blocked from there. Close to the infraorbital foramen. So if the nerve pain is on that area, infraorbital foramen could be blocked. Sometimes it could be through the jaw and this area, the mental foramen can be blocked. These are all the trigeminal branch blocks, mainly the superficial branches. Now coming to the first branch, that is the ophthalmic nerve. Ophthalmic again divides into three branches. This branching occurs before entering with the superior orbital fissure. So the nerve goes to the superior orbital fissure of the frontal nerve, which actually gives branches like the supratrochlear nerve and the supraorbital nerve. Then it divides into the mesociliary division, which is supplying the ciliary ganglion, as well as it is giving the multiple branches like anterior ethmoidal, posterior ethmoidal, long ciliary, and intratrochlear. And the last but not the least is the lacrimal branch, which is actually going through that to the lacrimal gland, and also the anastomotic division also goes from there. So this is how from the posterior to anterior side, this ophthalmic division is going through the superior orbital fissure. Now coming to the anterior side, this is the first branch, that is the frontal. They goes and they comes out through the, this is the supraorbital nerve, to the supraorbital foramen. And this branch is the supratrochlear branch. Now after ophthalmic, we are having the lacrimal branch, which is actually joining with the zygomatico-temporal branch of the maxillary division and ultimately supplying to the area of the lacrimal gland. And the third, but not the least, is the mesociliary nerve. This is the largest division, and then it again gives some branches. Branch I will come. So, as I told, frontal gives the supraorbital and supratrochlear. Similarly, the nasociliary gives the long ciliary, the posterior ethmoidal, anterior ethmoidal, external nasal, and the intratrochlear branches. So, these are all branches of the ophthalmic division. So, what we are blocking with the supraorbital branch, we are blocking this nerve. And sometimes if we go slightly medially with the local anesthetic, we can block the supratrochlear as well. So this is a common block that is employed when it is mostly towards the forehead, close to the forehead. The pain origin because of the maybe herpes or some other reasons, the pain is coming from there. It could be blocked at that area or because of the neuralgia as well. Now we have the ophthalmic artery, which actually goes with the canal, and then it divides into two groups of arteries. One is the ocular group, one is the orbital group. Now, orbital group supplies mostly the sides, not going to the orbit itself. Okay, so they are the lacrimal artery, supraorbital artery that we can see. We'll be able to see the supraorbital artery actually. Okay, then posterior ethmoidal, anterior ethmoidal, and the middle palpebral that we'll not be able to see. Frontal artery, also called the supratrochlear artery, sometimes visible with very good ultrasound. Otherwise, it is not visible mostly. Then we have the dorsal nasal artery. So these are the branches of the orbital. Ocular group are not important for us, but they are very important for the ophthalmologist because this is the artery, central artery. If it is occluded or blocked, consequence could be very severe. There could be loss of vision. But they are actually supplying the orbit and the accessory muscles. Now, to see the structures, the muscular area, there is the orbicularis oculi and the frontalis, they are covering this area. So whenever we are blocking here at the supraorbital foramen, so we are close to this muscle group. But remember, as there are multiple fibers here, it do not cause any problem while we are blocking. So this is the sensory area for the supraorbital and the supratrochlear nerve. They go side by side and they are supplying to this area. So any pain originating because of any lesion at that area, that can be blocked from your supraorbital branch block. Or it could be a simply neuralgia that can also be blocked by it. Now coming to the indications. First of all, trigeminal neuralgia, mainly involving the ophthalmic division to that specific area. Then we'll go for the supraorbital nerve block. Then I have told another very common thing is the herpes zoster pain. Mostly the acute herpes zoster pain responds better with the supraorbital branch block than the post-herpetic neuralgia. Then possible scar neuralgia of that area, quite common, sometimes it is possible, and that is also an indication. Post-herpetic neuralgia, in early stages, it could respond with it, but remember when it becomes central pain in later stage, it is very difficult. Next, for the laceration repairs at this area, it is very common indication. And for doing any procedure at this area, or if there is burn at this area, so there could be supraorbital nerve come into action. Complications are very rare, it's a very superficial nerve, but if the coagulation profile is hampered, there could be hematoma formation, there are possibilities of the intravascular injection, and if someone is giving with little knowledge, then there is chance of eye globe damage as well, and infection if you are not following a very strict aseptic procedure. So in ultrasound, we'll be seeing it's very simple to locate the supraorbital notch, and there we'll be able to see with the color Doppler the supraorbital artery also. Okay, but remember here also with very good ultrasound, you will be able to see the nerve clearly. But otherwise, you have to follow to that area. It's a very small area. If you give local anesthetic or if you give the neurolytic at this point, they will work. That is not a problem. Even the radio frequency or cryoablation at this area gives good result. Okay, because it's a very small area. Next come to the maxillary division. But before maxillary, this concept of ophthalmic is clear to all, the branches and everything, because maxillary is more complicated than this ophthalmic division.
Yes.
Okay, fine. So let's move to the next portion, that is the maxillary division. As I told, maxillary shows much more difficult route, and if we look one by one from where the maxillary coming and how it is differentiated. So within the cranium, before entering the rotundum, I have told you that it gives the medial and meningeal branch. So unlike the first division, that is the third division, that is here the recurrent meningeal branch is given after coming out through the foramen oval. So the branch enters through the foramen finosum. This is the first branch. But here, no such thing is there because it is given inside the cranium. After that, it comes out to the foramen rotundum and it comes to the area which is anterior to the pterygoid process of the sphenoid bone and posterior to the maxillary antrum, body of the maxilla. Now, that there it goes from the superior side. So, while entering through this gap, that means anterior to the lateral pterygoid plate and posterior to the maxilla. In between, then if you put your needle most superiorly, you will be touching this nerve, that is the maxillary nerve. If you are slightly below, then we will be touching the pterygopalatine nerve. Again, they are the supply of this sphenopalatine ganglion. Now, from the anterior and medial side, we have the median nerve entering, which is a combination of the greater and the deep petrosal nerve. They are supplying the both sympathetic and parasympathetic to this ganglion, and from where the greater and lesser palatine nerves are coming down. So, if your needle is up, then you will be in the area of the maxillary nerve. If your needle is in the middle, you will be in the area of the sphenopalatine ganglion. If you are further lower, then your chances that you are going mostly at the palatine. So here, after entering the foramen, remember, don't rely on any artery. It is rarely visible, and when visible also, you cannot 100% say this is the internal maxillary artery. Don't go on that. Go on stimulation and check which branch is being stimulated. Okay, and then perform the procedure. So this is going like this, and then it is following the for going through the maxilla and following the floor of the orbit. Okay, so here it is going through the few important areas. First remains in the middle cranial fossa, then it goes to the pterygopalatine fossa, then it goes to the lower border of the lower margin of the orbit above the maxillary antrum, then it goes to the face. So in this four area, the nerve traverses. Now the first foramen is the foramen rotunda. It passes it from the cranium to the pterygopalatine fossa. Then we have the infraorbital fissure through which it goes as the maxillary nerve to infraorbital nerve. So the nerve name changes as it enters to the inferior orbital fissure. Now it comes out through the infraorbital groove it passes, then infraorbital foramen it passes, then it is coming as an infraorbital nerve. So We have blocked here the supraorbital. Here we are blocking the infraorbital. So the area supplied by this nerve can be blocked here. But before that, we'll be looking at branches. One branch I have told you, that is the middle meningeal branch, which comes out early. Next comes branches from the pterygopalatine fossa. They are mostly the lower branches like the pterygopalatine nerves. They are going ultimately giving to the sphenopalatine ganglia. From there it is giving the nasal branches, nasopalatine branches, palatine branches, lesser palatine branches, and pharyngeal branches. But not that, it is giving two more branches here as well from the pterygopalatine fossa. Zygomatic nerve is also given at the pterygopalatine fossa, which again subdivides into zygomaticotemporal and zygomaticofacial, and which is passing through the zygomatic bone. Now, then the posterior superior alveolar division of the alveolar branch is also given prior to the entry to the orbit. So before going to this inferior orbital fissure, it gives this branch as well, which is supplying the posterior part of the alveoli. Then within the orbital part, mainly from this intraorbital fissure, before coming out to the face, it gives the another two branches, that is the infraorbital nerve, which divides into the middle superior alveolar and the anterior superior alveolar. So basically, these three forms the alveolar plexus around the teeth, and they are supplying for aperture. And the last branch, which is given after the infraorbital foramen, it is the infraorbital nerve. Then it divides into the inferior peripheral, lateral, external nasal, and the superior labial branches. So giving this area. So when we are blocking at this area, we can block only the pain originating from this area. If we can block at this area, we'll be able to block whole of this nerve. Okay. So with the ultrasound, we can block at this point and we can block at this point. So it depends on the what disease the patient is having, what is the pain area, and depending on that, you can block the part of the maxillary nerve. So here is the full of the maxillary nerve and maxillary artery. As I told, it is really, really complex. It gives multiple branches. Okay. So it is very, very difficult that when you are tracing that you are saying this is the supraorbital branch, this is the other branch. Anatomically, it is possible, but in practical, so many branches, and just with the blinking of this, it is not possible to differentiate each and every branch. Coming to the indications for the maxillary nerve block. First of all, definitely trigeminal neuralgia, which is involving the V2 division. And in spite of that, if there is cancer pain in that area or intractable pain which is not treatable because of any other cause, that could be possible to block by the maxillary branch block. Complications could be cephalalgia, facial paralysis, trismus, hematoma. These are possible, but they are comparatively rare. Now, regarding the ultrasound guided maxillary division block, remember the number of studies is very, very limited. Okay, so it is one of the review article that is published in 2020. They have given us this data that mostly people has gone for the maxillary division block through the infrazygomatic approach. Okay, there are 3 studies and there are suprazygomatic approach as well. Some has done it in plane, some has done it out of plane. But remember, this is a very small area. Going to that area in plane is quite difficult. Okay. So the results are not very, I should say, bad or good, because they have shown some good results as well. But the problem is the number of candidates. Okay. See, there are very few. They want case report. There are 10 studies, 15 cases. Maximum we got through the suprazygomatic route, only 60 cases. So we need more studies in that part to make it a standard technique. Definitely, it is not there. Now, approaches to the ultrasound guided maxillary nerve block are successfully described with the unique challenges. Ultrasound offers safety with the efficacy of advantages related to the real-time visualization of the vasculature, soft tissue along with the needle advancement as opposed to the standard fluoroscopy guided approach. We can see some more structures But when it comes to the inner area where the needle tip is going, in that area, still like fluoroscopy, this is also blind. It cannot see the artery. Structures of the tip and visualization can be obscure at times. Okay. Ideal approach is to be determined yet, and further studies are required. So that is the conclusion of this review article. Now the techniques here, what we will be showing is the ultrasound guided intrazygomatic approach that I have done in few cases. But remember, till today I have done as an assisted procedure with the fluoroscopy because I do not I cannot be 100% sure that the needle tip after doing it will be there and it is not going inside the vessel. So that gives us some advantages. But definitely researchers have done it without this also. I have done few hybrid techniques, but not entirely ultrasound guided procedure because I feel I could always be on the safer side. Now coming to the infraorbital nerve block with the ultrasound guided technique, this infraorbital and this supraorbital, these are quite easy and can be done easily. So here they are possible and we can do these blocks. Okay. Infraorbital foramen can be visualized in positioning with the ultrasound probe horizontally or vertically in the sagittal plane. It is, I will show it, it is very simple and everyone, you will be able to appreciate this. So it is not a very difficult thing. Now coming to the third division or the mandibular nerve. Remember, mandibular, as I told, after coming out from the foramen oval, the first branch from the trunk is a sensory branch, that is a nervus spinosus that goes back to the foramen spinal. Then from the main trunk of the muscle, it gives branches to the medial pterygoid, tensor tympani, and the tensor veliparotid muscle. So among these three, only this mandibular division is having the motor components, and these motor components are mainly coming from the anterior division and from the trunk. In the posterior division is mainly sensory, but only one motor component is there. So what are the branches from the anterior division? It is the nerve to temporalis, nerve to lateral pterygoid, nerve to masseter, and buccal nerve. So it is a very common question even for the NEET PG or an MCQ that if the patient is not able to open the mouth, which division of the mandibular does it is supposed to be damaged. That is the lateral pterygoid because it is having the motor supply from the anterior division of the nerve. But the posterior supply gives to the auriculotemporal branch, it gives to the inferior alveolar nerve, then it gives the mental nerve, and which gives the incisor branches, it gives the lingual nerve and the anterior belly of digastric and the mylohyoid, they are supplied by the posterior division. So here among those blocks, we can block at the level of the trunk before giving any branches, or we can block at the level of the mental foramen. So these are the two areas where we can block with the help of the ultrasound. So when we block with the help of the ultrasound for the mandibular division, usually the initial approach is same, that is the hitting the lateral pterygoid plate. Once we hit the lateral pterygoid plate, here at this point, the lateral pterygoid plate will be. So if I draw the lateral pterygoid plate, it will be like this. At this point, there will be the lateral pterygoid plate. Okay. And at this point, there will be the mandibular. Okay. So here is one gap. This is a gap in between. So this is for the maxillar division. And if we go slightly posterior, but remember this area is really vascular and the branches are there. And if we can get and stimulate here, this is the portion for the mandibular division. And when we stimulate the mandibular division of the nerve, we will be able to get the muscles of mastication, mainly the masseter temporalis contracting. So here we can use the nerve locator, or we can use definitely nowadays I do not have a nerve doctor as well. So every case I use the radio frequency needle, and it is very easy to stimulate with the radio frequency because in radio frequency we can both stimulate the sensory and motor. So that is how we will be going towards this division of the nerve, that is the mandibular division. And last but not the least, when it comes to the mental foramen, okay, which is close to the in between the first and second premolar, here we have to find out the mental nerve. And artery is very small. Sometimes it is take color with the ultrasound, but sometimes it do not take color. But always we see this bony break or the bony foramen in the mental area like this. and it is looking like this only. And here, if we put the needle and do the radio frequency or the neurolytic at this point, that would give you the result. So, what are the indications for a mandibular division block? First of all, trigeminal neuralgia involving the mandibular division, then post-herpetic neuralgia, cancer pain. Then complications includes the inadvertent intravascular injection, persistent paresthesia, infection, and sometimes hematoma formation. These are the possible harms of the mandibular division block. Mental branch nerve block is quite simple. It is limited to the area. Only when the small area of this area, chin area is involved, in those cases we can go for the mental nerve block like this. So nowadays, as we mostly use the radio frequency, our first choice always remains that gluing at the gastrin ganglion. If it's not responding or because of some reasons we are not able to do. For example, I got one patient, but there's a huge vertebral artery that is close to the area of the foramen muscle. So definitely I do not want to puncture that. So in those cases, the pain mainly was the maxillary division. I have gone for the maxillary division block. So unless there are some other reasons, we usually do not go for this branch blocks because definitely the problem with the branch block is not the efficacy. The problem becomes duration of pain relief. Branch block duration is usually less compared with when we do successfully at the gastrin ganglion. Because at the gastrin ganglion, all the cell bodies are there. So once you kill the cell body, the chances of nerve regeneration is comparatively less. But if you kill the axon, or if you hit the axon, again the nerve might regenerate through that area. So both pros and cons are there, and according to the patient's condition and the decision, you should are the final person to take the call whether you should go for the branch block, whether we will go for the one or many branch block, or we are going for the resident ganglion block. But ultrasound for this superficial three blocks, that means supraorbital, supratrochlear, and for this mental. For this, they are very good. But for the deeper blocks like the mandibular and for the maxillary, I should say you should always either do it a hybrid with the ultrasound or use a fluoroscopic guided technique. Though they have pros and cons, but definitely as the techniques are described in the standard studies, though the number of studies are few, but as we are doing hybrid, so once we get more expertise and we should go for these blocks with the ultrasound as well. Remember, these are the blocks that is previously done with the blind also. So ultrasound is definitely giving more advantage from the blind, but definitely as precision and the time spread what we can get with the help of the fluoroscopy guided is not possible with the ultrasound. So if you have any questions, I will answer that or I will go for the demonstration on the ultrasound. Any questions? Okay, no questions. Very good. Hope you have understood this anatomy and the first part of the anatomy, especially close to the middle cranial fossa. It is a little bit difficult to understand, but once you are actually used to with it, then it is very easy. Without this anatomy knowledge, actually, I think the things are incomplete. So let's move for the demonstration. Hello.
It's a question.
Hello.
No, I was more of a useful.
Hello, can you hear me? Sounds.
Yes.
Okay, fine. Thank you.
It's actually it's a promise character.
Okay, just 1 second. Let's check this the picture. Okay. Now you can see the ultrasound screen. And today, right now, I am using this straight flow. Okay. Because not all the superficial branches, we have to go through the straight flow or the linear. But for the deeper branches, we have to go for the curvilinear. So first, starting from the supraorbital side. So with the ultrasound setting, the frequency I will be going to the high frequency possible. Here, this probe gives up to 17 megahertz frequency. So I'm going to 17 megahertz frequency. Okay. And all the structures will be sent to the superficial focus is usually 1 centimeter is good enough. Okay. And again, I will be adjusting accordingly. Now I am putting this index marker on the marker towards the medial side. We the great side. So I just this away. Okay, can you see? Okay, this will go. So first, try to focus just above the arc. It's just above the arc. We are putting it. So we can see the frontal bone clearly. So the above you can see the frontal. Now let us increase a little bit of gain to show it better, reduce the depth is possible. Now as we are holding towards the junction the medial 1/3 and lateral 2/3 of the eyebrow and we are just putting it down. Then you can see a bony break here. Okay, so we can see that bony break here. If you go up, it will be a straight line. See, here it is straight line. As I am going down slightly, here you can see this bony break, and along which we can see one artery moving, and close to the artery, one nervous structure. So let us first, if you are, I can see the artery moving, but if you have any issues, you just reach on the color. Okay, and you see the color artery will take the color. So this is the area of the artery. Okay, so our lower part just ignore the most lower part. And here the artery is such at this point, it is mostly running parallel, so we can reduce the angle slightly towards the cranial side to see the artery in cross section. So now we are seeing the artery mostly at a cross section because artery is coming directly anteriorly. So if I am holding the probe directly from above, then the problem is sometimes the artery we are seeing is a longitudinal section of the artery. So sometimes it is difficult to visualize. But now, as I am putting slightly down, you can go more down, then it will be more circular. Okay. So here at this point, we are seeing the artery and nerve is always close to this area. Okay. So here we can see the nerve slightly above the artery. Okay. This nerve looks like going that is close to the bone. Okay. So at this area, you can see the portion of the nerve. That is the supraorbital nerve. Okay. That you can see with the cursor. So we have to go close to the artery. And when if you are using a better probe, like here actually today, I could not use my ultrasound machine at my clinic because that is most good for the superficial structures. But here I have to show superficial and deep both. In fact, superficial would be better with the Medigo, but it would be better with this machine. So I am choosing it because it is a very simple box and you can actually see this artery, go close to it, go close to the nerve, stimulate and burn. Okay, we get it difference. So that is the thing. If you want to give neurolitic, you can go and give a very small amount. 1 level of neurolitic is good enough here for this area. Okay, so this is the supraorbital nerve. Here, I think it is clear to everybody. Let's move to the infra. For the infraorbital, again we'll take some amount of gel all the index marker and everything like previous, that is the index marker is towards the median side. We are holding the row just below the eyebrow, and here we are trying to find out the body of maxilla. And from below up, we are actually going and we are trying to find out the forearm. And again, here we are finding the bony brain over it. So you can clearly see the foramen. Slightly, I am taking it more towards the center. So here is the infraorbital foramen. Once we look at the infraorbital foramen, we can switch on the color and you can see the artery moving. Again, to see it more circular, you can tilt it to see it more circular and close to the artery remains the nerve. Here also, identifying the exact nervous structure sometimes becomes difficult. With a bigger rope, it could be visible. And now, as I hold it more in a different fashion, so you can see at this point, we can see the nervous just above the nerve. Okay. So we have to go close to this structure and then we have to go for radio frequency. So that is the way. So simple. It's very simple. This sequence is very simple. You can put it here, move up, you find out the foramen, okay, make sure it is the foramen, give color, try to look at the artery, close to the artery, you will be able to see the nerve. Okay. Sometimes with a normal machine, it is 70 megahertz, depending the nerve is not very clear. So you could either equal 22 megahertz like mine, micro, or you can use the just grab the artery of the valve and give it close to that area. Okay. So that was the infrared. Now for the vector, we have to go slightly below and we should follow the mandible here. And this is a comparatively smaller one, and sometimes getting the artery at this point is sometimes also difficult. So for that, we have the first go from a midline towards the left side like this. Okay. So here I am lucky. Just when I hold, I got it here at this point. Okay. But it is a very small foramen, so sometimes getting it a little bit difficult. So see, here at this point, let us stop. Okay. Here at this point, we can see this foramen. Okay. So once we got the mental foramen, then we can go at this point and inject. Let us try in the color, whether it takes color or not. Most of the times my experience is not good with the color. Sometimes it takes, sometimes it could not. Sometimes here I can see a artery, but let's see whether it takes color or not. Okay. No. Now it is coming, but it is not taking out. That happens commonly, but nothing to it. Just go in that monitor, there is nothing in there, there is a superficial structure, and give it there. Okay. So further increasing color will not help. So that was the three superficial loss. They are very simple. I don't think you don't have much questions, but if you have, you can ask me. Any questions? No questions. Fine. Now we are coming towards the deeper block, mostly towards the mandibular and maxillary. And in this regard, you should first remember so what are the bone structure we are having from posterior to anterior side. So if you go to the most posterior side, there is the muscle. Then we are having the mandible, mainly the tamas of the mandible. Then we have the conoid notch. And within the conoid notch, we can see the lateral peripheral plate. Anterior to the lateral peripheral plate, we are having the area that is the gate for the inguinal ganglia. And the whole area through which we will be seeing the area in form of the infratemporal form. So now let's start with the same orientation. Volunteer this side, this marker on moving towards the to the hand side in the anterior side of the head, right side, posterior side of the face. So change the data at this point. First try to look at the diagonal. Okay. Take the row. So we are reducing the depth. And here my first thing is to find out the zygomatic bone. See, we can see the large zygomatic bone at this point. I'm showing it with the pointer. So this is the zygomatic bone. So now we can go infrazygomatic if we think once we find the zygomatic bone. So we can see the zygomatic bone at this point. Now we are coming down. So as we are coming down from the bone, we start seeing the deeper structure. And among those deeper structures, we have to find out the our gate. Okay. So here, the posterior most bone at this point, which is covering, is definitely the ramus of the mandible. Okay. Now, as we go towards the anterior portion, we can see another bone at this point. Clear? So this bony area is actually the lateral pterygoid plate. Okay. To see more, we can just rotate up and down to make it more clear. But here this bone is the lateral pterygoid. Now you can see one artery at this point. Okay, just behind the lateral pterygoid plate. See, you can see one artery, but remember it is not one artery, sometimes more than one artery is visible. They are all branches of the external canal. So the in this lateral pterygoid plate, in the posterior portion of the lateral pterygoid plate, lies the that's what's the okay, small and try to focus on this segment. Let's see whether we can see or not the color. No, it is not taking color. It is taking okay. Just before the noise, it starts taking color. But remember, we cannot see more clearly. Okay. So at this point, just posterior at this point, this is the area. So previously, in the blind technique, what we have done, we have hit the lateral pterygoid plate, going to the posterior side, and at this point, so it's a kind of vascular area. Here, multiple arteries you can see moving. So in this area, you have to find for the mandibular division of the arm. And to see the mandibular division, we have to come to the anterior side. This will improve the color. And just anterior to this plate. So this is our opening. Remember, here we can see only the opening. We cannot see the structures internally. Okay. So in front of the lateral pterygoid plate and this area, we have to put our nail. Okay. So sometimes in the increasing the want the features one regards. Okay. And here I can see only the area and some artery moving at this point. You see, that comes to my deep some artery moving. But remember, those one says this is the external cavity, internal maxillary artery like that. But I should not say this because the area is so deep and there are so many bones that we cannot exactly say that this is the internal axillary artery. But definitely, when we go anterior to the lateral pterygoid plate, this is our entry between the maxilla end, here the maxilla ends, and here the lateral pterygoid plate. So, in between this area, we are having this, our needle should go. And Inta asks the volunteer to open the mouth, open the mouth, open the mouth, open the mouth. Mukolo, argument. Okay, see, here is the branches of the masseter is moving. Okay. So these are the structures. So clearly one thing is important. This is our most important structure. There is a lateral pterygoid plate that needs to be identified. If you go posterior, this is the mandibular division. If you go anterior, it's the maxillary division. But internally, we have to move some distance to gain or to access this area. Okay. So even after I increase the gain, reduce the focus, I know I can do everything, but exactly saying that this is the artery. Okay. So, since some artery is there, but with that we cannot say this is the artery, actually artery like that. Okay. So, but your needle tip should be going through this format, that's for sure. And then in my 2-3 cases, it's not that I have done many cases of the mass initial block with the ultrasound. Basically, I have done just for seeing how it happens. So with the fluoroscopy, I have done it. So this way we can target the hit. But after that, all depends on where it is. In fluoroscopy, we can see that it is going to the lateral part of the lateral resolve, all that's all. In ultrasound, we cannot even see that. So that was today's 5 blocks, I should say. So any questions regarding any part? One chat question is there. Voice is not very clear, lot of echo. Yes, this room is not. This room is having some problem because this room is having not no absorbent substance here. So all it's a blank room. So it is a little bit equal hammering. Any other question? No questions. Okay.
I'm doing genetic. Hello.
Yes, I can hear you.
Yeah. I didn't understand the mandibular view we showed in the sonography.
You are doing mandibular sonography. Yes.
Yeah.
Yes, I am telling now. Those who are doing previously blind, so they can really shift and they can get a better idea comparatively. But those who have already shifted to fluoroscopy, and I am, for example, doing more fluoroscopy than this thing. So in those cases, now we always feel more comfortable in fluoroscopy in this area. Okay. But definitely, I should not say the ultrasound is bad or something because this is also a standard technique, and with the more number of studies, it could be possible. But definitely for the superficial branches, it is quite good. That I should say.
And this is a very old technique. We used to do blindly. Very long back, 10 years back, we used to do blindly. Just hit that lateral pterygoid plate and go posteriorly to get the mandibular branch. And there is one point, you should not go beyond 6 centimeter. It was written on the as a caution because earlier we could not see. So you should not go beyond 6 centimeter at least in a blind technique. Okay, so this I mean should apply here also. When you are seeing by ultrasound, you should not go more than that if there is any confusion.
So needle entry point is posterior, I mean caudal to the probe, right?
See, here I have shown you the
Otherwise,
number of I have shown you the number of studies. I, in most of the cases, gone out of plane because putting the needle here in the deeper branches with the in plane is very, very difficult. But if we see studies, the number of studies are also mixed. Only few studies are done in plane. Most of them they have done out of plane technique only.
so what I mentioned was now in the out of plane techniques, if we direct the needle towards cranial side of the probe, it is we can't visualize the needle. So we
Yes,
have
that's
to.
the problem. We cannot see the whole needle tip. It is not possible to see the whole needle because in outer probe approach, you see it as a dot. Okay. So only you have to make sure that you are going between these gates. That means anterior part of the lateral pterygoid plate and posterior part of the this thing, posterior part of the maxilla. So once you are inside the gate, now after that it becomes so deep, visualization becomes difficult.
So for radiofrequency ablation, I think combined hybrid technique or a fluoroscopy one will be a better technique than the.
Yes, that's why I always do the hybrid technique only. In this regard, I always prefer first definitely the gastrin ganglion block because the delay period is definitely more.
Yes.
And if the gastrin ganglion fails or due to some reason we could not do the gastrin ganglion, then only I go for the branch blocks. And in those cases, usually initial putting the needle, it helps, but ultimately you have to go with the stimulation technique. Because if we do with the fluoroscopy, we are ensuring that the no contrast is spreading to the vessels. Apart from this, actually, we do not have much more guide except for the stimulation. So two things can we see. Actually, it has gone inside the gate, it has touched to the lateral nasal wall, and nothing more. Even with the fluoroscopy, and contrast gives an idea you are not inside a vessel.
Yeah.
Here also we can find only the gate. After that, inside the gate, we cannot see definitely. Where is the nerve?
Yes.
Okay. So I think we can conclude today. So if you have any questions, you can write anytime through the app or through the WhatsApp group, anywhere. Okay, let's say bye bye today. I'll be posting the recording, the MCQs, and the write-ups.